Good evening, everybody. Thank you for joining us to the 107th session of Majlis Khonji. Please allow me to introduce our guest for this session, Professor Abdallah Daar, Emeritus Professor of Clinical Public Health, Global Health and Surgery at the University of Toronto and Senior Scientist at the University of Health Network. Professor Daar's academic career has spanned biomedical sciences, organ transplantation, surgery, global health, and bioethics. He has worked in various advisory or consulting capacities with the UN, the World Health Organization, and UNESCO, and he is the co-founder of Grand Challenges Canada. He was a member of the African Union High-Level Panel on Modern Biotechnology and currently serves on the AU High-Level Panel of Emerging Technologies. He is the recipient of the UNESCO Avicenna Prize for Ethics of Science. I would like also to welcome Dr. Dina Al-Asfour, a consultant at the World Health Organization in the field of primary health care and health systems in the Regional Office for the Eastern Mediterranean. Welcome again to Majlis Khonji. Dr. Dina, over to you and to our guest. Thank you very much. Stop, Dr. Dina, you're muted.
Thank you very much, Reham, and thank you very much for giving me this opportunity to be with Dr. Daar, an icon in the field, and has been our someone to look up for many years on the same screen actually. So it is an honor and a pleasure to introduce Dr. Daar. And please, Dr. Daar, without further ado, let's hear from you.
Thank you. Thank you very much. I am honored to be speaking yet again at the Khonji Majlis. I think this is my third time. I think once I talked about artificial intelligence, another time about COVID in an earlier stage. And now we're at a much later stage of COVID, and a lot of things have happened. So I have only 5 slides, and I hope that I will be able to cover a fair amount of what needs to be said about COVID at this point. And I've chosen a rather, what could be seen as a provocative title. Are we at the end? And you might ask, what do we mean by at the end? At the end of what? The virus is not going to end. The end of lockdowns, the end of fear and anxiety, the end of masking and distancing, the end of PCR tests, etc. So there is a lot to discuss with that particular title, and I hope that we will be able to cover some of those in my presentation and then a lot of it during the questions and answer session. I have been told that we have a total of a little over an hour from now. So I hope that I will talk for 30 minutes or so, and then after that, we will open it to the public, participants who are here to comment and ask questions, and I will try and answer them or comment back. So let's go to the next slide. So we have been through 2 years of hell since the beginning of 2020 to now the end of 2021 nearly. We were hit with this virus. We know that it is part of the corona family of viruses, which included others that had affected people in different parts of the world. And there are actually some flu viruses or cold viruses that are also corona. But this one hit us very hard because it gets transmitted very, very easily. It mutates. There were no medications specific for treating this particular virus. And it frightened people around the world, particularly because we didn't know what to do in the very beginning. And it disrupted our lives, and the virus itself was mishandled by almost every country right from the beginning. It was politicized, and it made countries be polarized. People used it as an excuse to have tribal wars, not so much in this part of the world, but in the United States particularly. It was very, very polarizing. We were saved by the arrival of vaccines, which were developed at a phenomenal pace. And in fact, one of President Trump's few successes, as far as I'm concerned, was to have put in place the warp speed program. And they put in lots and lots of money for a small number of research groups and universities to develop vaccines against coronavirus, and we will talk about the various types in a minute. And by the beginning of 2021, this year that we're in now, there were several virus vaccines that were developed, coronavirus vaccines that were developed. And that, in a way, suddenly changed the equation, because provided people agreed to be vaccinated, and that's another subject we can come back to later, provided people were willing to get the vaccines, particularly the ones that were approved scientifically after clinical trials, those vaccines did make a huge difference. And we will talk about the kinds of results that we see now in people who have been vaccinated compared to groups that have not been vaccinated. And then a question at the end we need to discuss is, can we see now the light of day? Are we going to get out of where we are now safely? And what's going to happen in the next year or 2 or 3? So those are the kinds of things that I look forward to discussing with you in more detail. Next slide, Rehan. So since the subject is so huge, so vast in terms of the different aspects, I thought that I would do this kind of presentation. So I have 2 of these, and we could spend a lot of time on each one of these. These are called word clouds. And what they do is they represent what was discussed in the world, in the media, in social media, in personal conversations and so on, related to coronavirus. So for example, this particular format that we're using today, Zoom, suddenly became the way for people to communicate. Before this, Zoom was just beginning to come into play, but as soon as the coronavirus hit, millions and millions of people downloaded the app and started using it as we're doing today. And that became a subject of conversation in its own right. The other big thing that became prominent throughout the world is remote remote learning. So kids stopped going to school. They were studying at home. And there was also remote work. People stopped going to offices and were using Zoom and other methods of working from home. And in a way, both remote learning and remote work became so successful that now that coronavirus is coming under control, people are questioning whether they need to go back, particularly to remote, to physical, going to the office. And a lot of people are reluctant to go back to the office and are saying, we're very happy to work from home. Maybe we'll come to the office 1 or 2 days a week, but most of the time we're happy to be at home. It increased quality of life with families. People spent more time with their children than they did before. And on the whole, this particular part, the remote working and remote work and remote schooling, has changed many lives, and it is something that has led ultimately to what's now called the Great Resignation. A lot of people are no longer willing to work in the jobs that they did before. So now we have a new thing which we don't have on any of the slides yet, and it's called the Great Resignation. People decided that it's not worth going to the jobs they were doing before. They thought that the pay that they were getting and the conditions under which they were working was no longer what they were looking for in life. And particularly in the West, where governments poured in trillions of dollars into the economy to support the economy and to support workers who'd been laid off and so on. So they spent trillions. So a lot of these workers were now being supported by government money. And so suddenly they realized, well, you know, maybe there is more to life than going back to the stupid job that I had before. So that's a very interesting development. Then, of course, we had masking. So masks became so prevalent. Everybody was asked to wear masks, and on the whole, people respected that request by governments. And in some cases, these were mandates. People were mandated to wear masks. They had no choice. To some extent, this still happens. If you go to a supermarket in many parts of the world, they will not let you in if you're not wearing a mask. And in addition, now, they will be asking you to show proof of vaccination. So that has been a wonderful development for controlling the virus, that people are being pushed into getting vaccinated and to wear masks. We also heard a lot about variants of the virus towards the end of 2020 and more into 2021. We were beginning to see these variants. And initially, they were called variants that started in Sussex, in the UK, variants that started in South Africa, variants that started somewhere else. And this got out of hand. And then people said, why don't we just name them after the Greek alphabet? And so Delta is from the Greek alphabet. Some of the things that we also saw on the medical side is mental health deterioration in many people. Many people couldn't take the idea of not being able to go out to meet other people, being shut down in their apartments and homes. This affected the mental health of many people, and it is something that will take a long time to deal with, because you can't take care of mental health by just switching off the stimulus. or reducing the risk. It'll be something that we will have to really, really take care of. And then the lockdowns themselves were something that was part of the conversation in almost every country in the world. Some countries did this for long periods of time, and that, of course, affected the economies of countries. The economies, particularly in poor countries, particularly those in Africa, were totally devastated because of the increased demand of health care in hospitals. The healthcare facilities were also put at huge, huge pressure. And we saw this on the news in many countries, beginning in Italy in 2020. Later on, we saw this happening in countries like India, where people were dying, 10, 15,000 people were dying a day. It was just horrible seeing those scenes on television of Indian places for ritual disposal of bodies, not being able even to find the wood to burn the bodies. It was very, very sad to see that. Surprisingly, even countries like the United States, which are so well endowed with healthcare facilities, with the ability to vaccinate and so on, the United States lost 750,000 people. These were the figures as of last week. They will continue to increase. Very, very sad that that happened. And of course, that also happened in large numbers in Brazil and other countries, particularly those countries that politicized the virus, like Brazil. And throughout the world, the number of people officially that have died is 5 million, but actually the number is closer to 17.5 million people have died around the world. Those are the figures provided just this week by Economist magazine that did a really good study to look at the number of people that have died in excess of what you would expect people to die in those countries since COVID started. And the numbers are now at 17.5 million. Let's go on to the next slide. So more of the word cloud. And now the conversation is changing already, as you can see. We are talking about learning to live with the virus. We are learning to say, okay, we will no longer pursue elimination of the virus, and we will be talking more about how to live with the virus. And apart from China, which is the one major country that is still working towards elimination of the virus, and I'll come back to that in a minute, most other countries are beginning to have the conversation of, okay, how can we live with the virus? How do we increase the number of people vaccinated? How do we decrease the number of people that are refusing vaccination? So one of the early success stories in the world in terms of having very few numbers of COVID deaths and COVID cases was, for example, Singapore. Singapore, as of last month, decided we're not going to work towards eliminating the virus, we're just going to work towards controlling it and living with it. Similarly, one of the early success stories in the world was New Zealand, which everybody was talking about, the exemplary country of how to cope with COVID. They changed their approach last month from trying to eliminate and complete lockdown, nobody can come, etc., to saying, okay, we will learn to live with it. At the same time, countries that have had very, very long lockdowns, like Australia, have now opened out. So Australia now, people are free to go and come, to go to restaurants, to live a near normal life. There are still recommendations to wear masks and social distances. We have also started seeing variants beyond Delta. And to some extent, this is worrying because it means that the virus continues to mutate. And it doesn't necessarily mean that the new variants will be worse than the previous variants. So it might be that the new variants will actually be less lethal than Delta. We don't know yet, but the important thing to say about this particular point is every country should have the ability to do genetic tests on the viruses that are circulating in that country, on the coronaviruses circulating in that country, so that if there are new variants, they will be picked up very rapidly, and that information will feed into vaccine manufacturers who can very quickly tweak the vaccine from dealing more with Delta to dealing more with other variants that are coming. So this is the implication of why you need to do those genetic tests all over the world. Another thing that is now becoming very important is this issue of long COVID. Long COVID is the remnants of the symptoms after you have had your acute attack of COVID and recover. Attack of COVID, but it leaves symptoms that continue afterwards, or it might be people who had very severe COVID and went into ICUs and were on the point of dying, but then recovered. And those also now have long COVID. And it is estimated that 30% of all people who have had COVID will have long COVID. And we are now at a stage of providing definitions and finding solutions to the symptoms that people have. Because the symptoms can be very severe. They can be, for example, neurological symptoms. They can be, in essence, in any part of the body, you can have long COVID. And we do not yet know what effect this will have on the healthcare systems. But I suspect that it will be something that we will be faced with in a serious way, either as inpatients, but more likely as outpatients. We will have to develop long COVID clinics in hospitals to deal with patients who are suffering. So that is something that is coming. The other thing that we're beginning to hear now is supply chains. So because of lockdowns, because of restrictions on movement of aircraft and ships and so on, supply chains have been really, really disrupted. And this means that if you want to purchase stuff for Christmas or Eid or whatever you want to purchase, gifts, a lot of those will not be available for a long time. You might have to wait for quite a long time to be able to get those supplies. And something else is the fact that we have run out of microchips. So microchips go into building cars, computers, lots of electronics. And now that we have run out of microchips because of COVID, all those items are either not available or they cost much more. So for example, second-hand cars now cost much more than new cars because you can't get new cars and everybody wants cars and they're buying second-hand cars and the price has gone up because of the demand. So that is also something that we will have to deal with in the coming months. Let's go now to the last slide. So we are getting to the end of my presentation and then we'll open it out to the participants. Now, what can we foresee today as things that are likely to happen, very likely to happen? So we will continue to need vaccines, including new vaccines, into the foreseeable future, because at least for the next 3-4 years, the world will not be fully vaccinated, particularly the developing world. So there is this thing about vaccine equity, vaccine justice, in the sense that people are now getting booster doses in the wealthy countries, and yet people in the developing world are not getting any. Less than 1% of people in much of the poorer countries, particularly in Africa, have not been vaccinated. And those people, if they're not vaccinated, that means that the virus is around and it'll come and hit us in the other countries where we live. So we are not safe until everybody is safe. That's the motto with regards to vaccination. So it's unlikely that we will be able to vaccinate the whole world to the level of what's known as herd immunity, and we can come and discuss what that means in the next 3 or 4 years. It seems to me like we're talking about 5 years before we reach that point. And the implications for this is you cannot trust the vaccine manufacturing companies to prioritize the poorer countries. And this means that the poorer countries must start making their own vaccines. And so we will come and discuss what's happening in Africa, for example, where the World Health Organization is working with South African biotech companies to develop coronavirus mRNA vaccines in South Africa. And they will ignore the intellectual property restrictions, particularly for one of the 2 mRNA vaccines. That company, not the Pfizer one, the other one, have said that at least for the next few years, we will not enforce intellectual property protection. So go ahead and try and make it in South Africa. And I think we will see that. But of course, that won't be immediate. That'll take a year or more before we begin to see vaccines being manufactured in South Africa. And then that particular facility in South Africa is going to be like a university, and other countries in the world that need to be making their own vaccines, particularly in Africa, can go to South Africa and learn how to make those vaccines and take that knowledge and go and apply it in their own countries. So that looks like a good thing on the horizon. Now, vaccine companies, unfortunately, have been very greedy and have sold their vaccines at a very high price. Other than AstraZeneca. AstraZeneca is a company that took the Oxford vaccine and started manufacturing it in India. India is the largest manufacturer of vaccines, and has from the very beginning said that they will sell it at cost. They will not seek profits from this. And indeed, AstraZeneca vaccines are the least expensive of these new vaccines. Now, one of the biggest problems that we have, and this is a really big problem, is this issue of disinformation and misinformation. Misinformation is taking the videos that we see on WhatsApp and so on, and just distributing them to other people on WhatsApp and Twitter and so on, without thinking if that information is accurate or not. Disinformation is different. Disinformation is actually beginning the process of lying about vaccines. And then having developed a video with your lies in it, you disseminate it throughout the world on social media, etc. And this is something that people are doing for malicious reasons, just like there are people who start fires in the world. They just like to see the world burning, and they are doing this for malign reasons like that. Others are doing this because they believe that the vaccines are harmful, and they want to stop people from using and getting vaccines. So they are the anti-vaxxers, as they are known. And some of those are specific anti-vaxxers for coronavirus vaccines, and some are just anti-vaxxers generally for any vaccines. They don't want to give their kids any vaccines, and so on. And this, I think, will be a problem that won't go away. I think this will continue to be a problem for as long as we have coronavirus. Whether, you know, the law will be brought to bear upon such people, such groups, some entities, these entities, and stop them legally. We don't know. We don't know yet whether that'll happen. Now, there are other interesting things that have happened recently since I made these slides that I need to tell you about. And one of these is about antivirals. So we heard a major breakthrough from a company called Merck, which developed a antiviral molecule, which you take 2 tablets a day for 5 days, and it's called molnupiravir. Apparently, the name comes from the hammer of the god of thunder in Norse mythology. They use that, saying that this is a hammer that will hit coronavirus. So molnupiravir. Now, why do I think that this is going to be the most important breakthrough for now? And that is that this is given orally, and you can therefore take it at home. If you begin to get the symptoms, you can test yourself, or even before you test yourself, you can start a course of this antiviral. And it is supposed to cut, at least in clinical trials, the severe forms of coronavirus that require you to go to hospital, put on a ventilator, and die by at least 50%. And this particular drug has now been given regulatory approval in the United Kingdom. It's the first country, I think, that happened 2 days ago, and it will happen very soon in the rest of Europe and also in the United States, and hopefully throughout the world. And what's interesting is that Merck here is acting in a very ethical manner. So Merck will sell the 5-day course in poor countries for $20. In rich countries, it will sell for $700. And this means that people in poor countries will be able to afford this. A lot of people, not everybody, but it will have an effect. because the more people who take this medication will stop getting to be able to transmit the virus. And so the level of virus in the population will go down, particularly for people who've been vaccinated, and so on. So it's a company that we should praise when we have the opportunity to do so in social media and so on. And it's also, interestingly, allowed developing countries who can manufacture it to go ahead and manufacture it. And it's also allowing companies that make generic drugs. And there are countries like India that have many, many, many companies that make generic drugs. And so those countries can just go ahead and start making them without worrying about intellectual property protection and so on. So this is a great company in this particular case. We should respect it. It's called Merck in some countries, and in some countries it's called MSD, but it's the same company. Now, Pfizer yesterday announced an oral antivirus called Paxlovid, Paxlovid. Now, I don't think this is going to be as successful as the one from Merck, because Pfizer is a greedy company. We have seen how greedy it is. And it will not sell it for $20 in developing countries. It's very, very likely going to say we want to recoup our research dollars and so on, and hit the public with very, very high costs. And the second thing, that is not a single drug. You need to give Paxlovid with another antivirus, which complicates the regimes. Instead of taking for 5 days, we don't know yet how long this will require to be taken. And they have not yet got peer review in journals, so the research has not been submitted to peer review, and also it hasn't been approved as an emergency use drug in any country yet. So we really don't know where we are going with that. The other thing is, you will remember that last winter, the last northern winter in the Northern Hemisphere, there was practically no flu because everybody was masking. And so flu was not transmitted. Kids didn't get it in school and bring it home, where it's normally transmitted, or in the public, where flu, people get it from coughing and so on. And that didn't happen because of masking. So now we realize that masking has a benefit beyond coronavirus, and hopefully this winter that's coming, people will continue to wear masks, and more importantly, perhaps go and have flu shots. So go and have flu vaccinations as soon as they're available in your country. We know that the new flu vaccine has already arrived in many countries. And I say the new one because every year there's a new flu vaccine. And the reason for that is that flu changes, mutates, the virus mutates very, very rapidly. And so every year there is a new flu vaccine. So go ahead and have that, unless you have a contraindication to getting the flu vaccine. So I'll stop there, and we can go now to the next phase of our discussions today, and I'm open to questions or to hear your points of view. Thank you very much.
Thank you very much. Thank you, Professor Dar, for the informative presentation. Dr. Dina, if you would like to start the Q&A session, please.
Okay, thank you very much, Dr. Dar. That was very enlightening, and it brings a lot of questions, I'm sure, in many people's heads. Before we proceed, Rehan, would you like to put on the slides?
Yes, yeah.
Was asked to give just a brief on the situation in Oman right now. So we'll
Yeah.
just
Just a second, I'm putting them on.
okay. So this is very briefly. I'm going to talk about how Oman is within the Eastern Mediterranean region. So the slides are not very clear, but we are in a very good situation because as you can see, the last week we had only 8 cases. Compared to other countries that has many cases. Also, in most of the Eastern Mediterranean region around us, the countries around us, there is a big decline everywhere. The only country that there is an increase is Syria and Iran and Egypt. The next one, Rehan, please. Rehan?
Yeah, are you able to see it or?
Yeah, give me I want to see the next one, the second one.
Yeah, sure.
Okay, in any case, the situation in Oman is more or less very good. We have, these are the number of cases over the last week per 100,000. And you can see Jordan and Iran, Lebanon, Libya are very high up, whereas Oman is among the lowest countries. The next one.
Yeah. Sorry, it's just I have to.
That's okay.
Undo this. Yeah.
And this is how what happened over the whole time of the pandemic. Right now, we have 304,000 confirmed cases. Out of them, 4,112 deaths. As Dr. Dar had mentioned, the actual toll of death could very possibly be much higher than this. This is, I believe, because there is the deaths that are secondary to COVID, but also the deaths that happened because of the unreachable health services during that time, and people have died because of that. So now I would like to open the floor for discussion. If anybody has questions, could you please raise a hand?
Yeah, so if we have any questions, if no questions, Professor Dar, I would just like to highlight on the last point that you have spotted on the flu vaccines. We have recently noticed that since the schools started, and I have experienced this with my kids even, yeah, it's the flu had come back again very strong, and most of the kids got it. And for the first time, when we visited the doctors in 2 private hospitals, they said, please come and take the flu vaccine. We never used to hear this actually. So as a family, we've decided, yes, why we don't take it? Because it's a disturb. If a kid, any kid get it at home, then, the parents also will start to have it. So the kids will have to stay and the parents. So I think that's a very important point, because the symptoms are very strong for a kid, fever, and so I think that's a very important thing that you have highlighted.
And it confuse the picture that you don't know, is it corona, is it flu?
Exactly.
When they
Yes.
start going to hospital, if it's corona, they'll pass it around. If it's flu, they'll pass it around. So you're quite right. Thank you for bringing that point up.
Yes, you're right, because they are not even allowed from the school gate if they are coughing, even if it's not COVID. So it's a disturb for the whole family, especially for the working parents. Thank you. So Mr. Shawqi, yeah, Mr. Shawqi.
Oh, okay.
Yeah. Mr. Shawqi, please go ahead.
Yeah. Thank you very much indeed, Professor Dar. Abdallah, it was very informative. There seems to be a bit of a confusion on the PCR tests around the world at the moment.
Right.
And, the cost of travel at the moment is so much linked with PCR, in the sense that you get to a country where, I mean, I was in Germany a month ago, and from Germany, I went to England, and then I came back home. So I left here, went to Germany, England, and back home. And the cost of a PCR, for example, in Germany was, for one person, was something like 275 euros. The cost in England was 100 pounds. The cost here before I left was 80 Omani riyals. And then the cost, so when you add them all up together, they're actually almost worth the cost of the airline ticket from here to England and back again. And what I cannot understand is that there are now tests that could be done at home for very small sums of money. What is the problem? Is it commercialization that is restricting the spread of a PCR test to the home in a cheap way, or is it politicized, or what is your take on it?
Right, thank you. That's a really important point. The new lateral flow or protein tests cost about $1, maximum $2, as compared to 100 pounds in England and 50 riyals in Oman. I think that it's a combination of the following. One, that these are commercial companies and they are pushing this for profit. Secondly, the medical community has not yet caught up with these technologies so that they can advocate and advise their governments that the cheaper versions, the $2, $1 versions, the lateral flow, are just as good for public health purposes than the PCR. They're just as good, in some cases even better, because a lot of these commercial companies doing PCR, actually they are charging a lot of money, but at the same time giving false results or inaccurate results. And thirdly, these lateral flow protein tests can actually be done at home. You can go to a pharmacy and buy a kit and do it at home. And you will be able to do it in such a way that you can take that as evidence that you are negative. Or even simpler, when you are at the airport before you board a flight, or when you land, say in London, they do this at the airport, and it takes 5 minutes to give you them the results to let you through. So those are the reasons. I think it's important that governments start realizing that PCR is not needed anymore, that we can cope and do better with these fast tests for public health purposes. So that's the answer to your question, Shawki.
Thank you.
Thank you very much. Thank you, Mr. Shawki. That was a very important point. And I think Mr. Azim Mutani have said the same. He said it was an excellent point by Shawki Sultan. Just wanted to address the same point. Yeah. Do we have more? Yes.
That is for Azim is in Canada or the United States. So it's very nice to have people joining in from.
Yes, Mr. Azim, please go ahead. Yeah.
Oh, yes. Hello, this is Rose.
Sorry.
Azim.
Sorry.
That's fine. It's Azim's wife.
Yeah.
Hi.
Yes. Yeah, Azim is here as well. Yeah, thank you very much. That was really very informative. I'm glad I was able to join in. We were able to join in.
Is this Roseman speaking?
Yes, Roseman.
Okay,
yes.
Roseman, we grew up together in Tanzania.
Exactly, yes. So it's even more of a pleasure joining in and
Yeah.
You remind me very much of your father.
Oh, thank you.
Yes.
He was a very good looking
Yes, yes. Very nice man.
Yeah.
Very good man.
Yeah.
Good friends with my father. So, Abdallah, you know, double vaxxers also catch COVID.
Correct.
It's
Yes.
known.
Yes.
And I was wondering, is there a certain profile that they fall into? Because it's a bit worrying that, you know, even when one is double vaccinated, they catch COVID
Yes. Yes.
and die.
Rarely die. Rarely die.
Okay.
The majority of so-called breakthrough COVID is mild, and people are now so familiar with how to deal with COVID. They can go have a booster shot. They can have monoclonal antibodies if those are available, or now they can use the new antivirals. But the point is, biologically, we are seeing that people who are vaccinated can have breakthrough. But the important point to remember is very few of those are severe. The majority are mild. They happen in immunocompromised patients. So, for example, Colin Powell, who died about a week ago from
Yes.
breakthrough COVID, he
Yes.
died not because of the COVID. He died because he had very advanced cancer. He had a cancer that completely destroyed his immune system. And that's what we need to be talking about when we talk about these breakthroughs in people whose immune function has been compromised. But thank you, that's an important point. Thank you.
Right. So it's mainly the immunocompromised people.
A lot of them. A lot of them.
So Mr. Shawqi had another question also. Yeah, go ahead.
Then Abdallah Al-Harthi is also waiting.
Okay.
Sorry. Abdallah, you can go ahead. I will ask the question later, but if you want me to, I've got a very quick.
Since you are there, go ahead quickly.
My question is this, that I read that AstraZeneca, sorry. That AstraZeneca were publicizing the information that if you have taken their vaccination, that you do not need a booster, as Pfizer were saying that you do. Now, is that a fact, or does one have to go and take a booster irrespective of which type of vaccination that one has had?
Yeah. So a lot of countries, Canada, for example, are recommending that if you, whatever you've had before, have a booster which is different from the one you had before. So if you had mRNA before, now go ahead and have the one from AstraZeneca. And there is a reason for this, because the more that the immune system is exposed to different variants of or different configurations of the virus that are in different vaccines, the more likely your immune system is to produce a vigorous and good response. So I would say go ahead and have a booster if it's been given in your country. And if you can, have a booster that's different from what you had before.
Okay, thank you very much, Dr. Abdallah. Would you like to ask your question?
Assalamu alaikum, Prof.
Ya hala, Abdullah.
It's so good to see you. We haven't met since before the pandemic, so hopefully now we can see you again soon.
You have moved now to another hospital.
I have, and Thursday was my last day in that hospital, so I'll be moving again soon. So, you know, that's life.
Okay.
My thing was, you know, throughout the pandemic, we have been focusing a lot about the death toll or the cases of COVID themselves. But you know that the resources of the healthcare system are quite limited. And what we faced was that we had to divert a lot of those resources from quote unquote, non-essential areas to the treatment of COVID. Now, something that we were expecting to last for approximately 8 weeks, now we find ourselves 18 months in.
Yeah.
And a lot of other services were affected. Now, I don't know if you have any idea globally of the non-COVID deaths that happened because of the pandemic. That's
Yes.
one. The other thing is we are finding ourselves these days in this euphoria of that COVID is over, vaccines are widespread, but the problem is the recovery is not as easy as people think.
Yes.
And as you mentioned, the big resignation is not only happening in the, let's say, the service industry, the healthcare system. We have a lot of either burnout or we have people being offered jobs like in the UK and Ireland. So the recovery is becoming very challenging. So I was wondering now, finding ourselves in this situation, the ethics behind people not taking the vaccine and us, for example, delaying oncology procedures or other procedures so we can treat people who have refused to take the vaccine themselves.
Yeah.
I know it's a big thing, but
No.
that's why they give you the big bucks.
And it also reminds me to address one or two additional. So, first of all, your comment is about what could be called collateral damage, in the sense that hospitals are overloaded with corona patients, and so you cannot get patients who've got cancer, who've got orthopedic problems, etc., to access those services, and so they are suffering. In those countries which have been able to control the virus and have very few numbers, the problem that you're describing with the collateral damage is much less. So for example, in Oman, although theaters have been closed in some places, other places are now able to take on patients without COVID and treat them. So that is a problem that might get better in countries that the numbers are going down. But remember that there are countries now in Europe, for example, is having the 4th wave. The numbers in Germany are the highest now than they have ever been. Unbelievable. In the UK, the numbers are very high. And in other European countries also, the numbers are very, very high. Now, some of this is due to children getting coronavirus. But now, as of 2 days ago, the regulatory authorities in the United States have allowed children to be vaccinated, those between the age of 5 and 12. And the same is happening in countries in Europe, and that'll reduce the numbers of patients who get coronavirus either directly or because there is diminished communal transmission. I think in Oman also, I'm not sure, but you can get vaccines for children between 5 and 12. I'm not sure, but if it is, it's very good. And if not, we need to talk to the Minister of Health and advocate for that. Now, the other question is burnout. And this is a really big problem. And as you say, some of our staff, nurses and doctors, maybe not in Oman, because Oman is such a lovely country to work in, but in many countries, they're emigrating to richer countries. And the interesting thing is that in those countries, those new doctors and new nurses that have come from elsewhere, a lot of them are of Asian origin. And as of this week, we have learned that actually South Asians, Indians, Pakistanis, Bangladeshis, have a genetic makeup that makes them a little more vulnerable than the rest of the population. which is for them very dangerous. However, having said that, and this is the point that Talal al-Awlaqi is trying to make, is that the social determinants of health overwhelm the genetic determinants. So you are likely to be affected more because of the social circumstances, the way you are exposed, access to healthcare yourself, the PPE that you have access to. And apparently, in the United Kingdom, Asian doctors don't get access to the same PPEs as other doctors. Secondly, they are at the front lines, whereas the white doctors in those countries are in management positions. So there are a lot of things to think about, but all those can be put in the basket of social determinants as opposed to the genetic. But it's interesting, and this is the first time we have seen a genetic predisposition. And it's early days, the paper's just been published. We will need to see whether, as we accumulate more evidence, this persists. Thank you.
Thank you very much, Dr. Abdallah. Dr. Dina, please.
Yeah, thank you, Reham. Is there anyone else who who had a question, Reham?
Dr. Talal, do you would like to share any point or to ask any question?
Dr. Talal?
Thank you very much. Really, it's a great learning from you, Professor Abdallah, and thank you, Dr. Dina. So I'm learning. I have no points, so thank you very much. Really. Thank you.
Okay, all right. Okay, I think we shall call it a day here. It has been a little bit more than 1 hour. Thank you very much, Dr. Daar, for all your insights into what is going. Hopefully, you know, I know it's not easy to say when all of this will end, but yeah. I think it's a learning curve for all of the health policymakers and academicians and everyone, in terms of understanding how we can deal with emergencies and catastrophes such as this.
Yeah.
Hopefully nothing happens in the future, but God forbid something should happen. We need to be prepared and know and learn from our mistakes. So thank you very much. Do you have a last word, Dr. Daar, you want to say?
Yes, I don't think this is going to end soon. I think that there will be another opportunity for Majlis Al-Khonji to invite me or another expert to talk about this subject.
Mr. Khalid, would you like to say anything?
I think
No,
he yeah,
you
I
mean
think he will be in his flight as of now.
All right. Okay. So okay.
That was the airport when he discussed. So,
okay. Well, thank you. Thank you for all the participants for their for joining us, and thank you, Reham, for inviting me to be part of this Zoom. Hopefully, sometime in the future we can do it physically, and we can greet each other and talk to each other in more detail. Thank you very much, Dr. Daar, for your time.
Okay,
thank you very much.
Thank you for joining us.
See you next Saturday. Thank you very much.
Bye.
Thank you very much.
Thank you.